Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. In this particular video, there's two procedures. The first procedure you're going to see is patient A, and patient A had been using cotton buds, what's known Q-tips in America, and they had pushed this wax against the eardrum. Whilst the second case, patient B, the earwax is more lateral near the entrance, and hence the name of the video. So close yet so far. So it kind of illustrates the different cases we can see in clinic. Every patient's different, the location, the consistency of the wax. And with this patient A's right ear, there's actually dead skin, it was dead keratin. And you could tell that by the coiled appearance. And that was impacted against their eardrum. You can see the eardrum's visible now. There is a slight attic retraction. So at the top of the eardrum is buckled inwards, and that's due to a blocked eustachian tube. And there is some dead skin on the eardrum here. Now, I felt comfortable removing it as much as possible anyway. That was able to come off with little resistance. So I'm just using a fine end suction probe here. And just kissing the surface of the eardrum, trying to lift this dead skin off the eardrum. Now, it would probably come out naturally, migrate off the eardrum in the next couple of weeks, but the patient was still, I felt comfortable just approaching the eardrum and making just gentle contact with it. And it's just a bit here, just to the left of the hammer bone. You can see the hammer bone running from top to bottom there. And then I think this is the last bit that I decided to remove. Everything else was a bit stubborn, and you can see the whole eardrum now though. But yeah, the patient's got a bit of an attic retraction. They've got a blocked eustachian tube. They had a bit of nasal congestion, which blocked their eustachian tube, which is a tube that connects the middle ear to the back of the nose, which then creates a vacuum effect behind the eardrum, and the eardrum can buckle inwards. They've got some nasal decongestion sprays, and hopefully that will do the trick. So in this side, similar problem. It's actually dead skin again, but it's been there for a bit longer. It's oxidized. So this is not wax. It looks like wax, but it's actually dead skin again, and it's coiled. It's got a glossy appearance, and that's just been there for a bit longer. Hence why it's darker. That wasn't impacted on the drum. Also on the right side, the patient had been using drops, which can sometimes discolour the wax as well. On this side, they hadn't. So I'm just mopping up near the entrance. So both ear canals are completely clear, both eardrums are visible. There's no retraction here. So that's patient A, and patient B, so this is patient B's left ear. Now, this plug of wax skin, it's matted, you see all these hairs, and this is near the entrance, so it's not deep in the ear. So it just gives you some perspective of the ear canal itself. So the ear canal on average is it varies obviously between adults and children. An average adult's ear canal is around 2.6 centimetres. Male ear canals are slightly longer than females. So that plug of matted skin keratin's been removed, just a bit around the edge. I'm just using the Zollner suction probe to perform microsuction just to lift it off the canal wall. There's a bit here to the posterior lateral canal wall. You can see all those hairs that are attached to the wax as well, and we're just giving it a little wriggle at the top just to elevate it, detach it off the roof of the ear canal. So you can when you're performing clinical ear care, you're going to be comfortable removing wax from all regions of the ear canal, not just the entrance but also the eardrum, and for that you need a good view. And you can see the view that we're getting both with the endoscope near the entrance and also when we zoomed in on patient A, against working directly on the eardrum itself. So that's the patient's left ear. And in a minute, you'll see similarly the patient's right ear. It's a nice healthy eardrum, good light reflex there. So if you've got a healthy eardrum, typically you have a reflection back off the eardrum. We call it a light reflex. So the light source that we're using to illuminate the ear, that reflects off the eardrum. And again, so this is just past the first band. You can see all these hairs. That's a good indicator as well that we're near the entrance. I'm just trying to get a suction grip. So quite dry wax here. Now, could have used probably an ear hook, but we're using suction already. And I'm just teasing this out. So with this, the plug of wax and skin did extend deeper in the ear, but we're removing it near the entrance. We're not having to go deep in this. If we use the hook or scoot, we'd have to probably insert that deeper in there to get in and behind this matted plug of wax and skin, but sometimes with suction you don't have to go deep in. We can just remove it by getting a suction grip near the entrance and bringing it outwards. So again, that's the patient's eardrum, nice and healthy. You can actually see the incus there as well. So the eardrum is slightly translucent. If you've especially with children or younger patients, it's a bit more translucent, and you can visualise the second of the 3 middle ear bones. So there's 3 bones in the middle ear. You'll probably know them more as the hammer, anvil and stirrup. Medically, the hammer bone is called the malleus, the anvil is called the incus, and the stirrup is called the stapes. Very rarely can you see the stapes unless the eardrum's really retracted, so it's sucked in and it's wrapped itself around the stapes bone or the incus bone. We should be able to see the hammer bone in everyone's ears. If we don't, then something's not right. And the incus, the middle bone, sometimes it is visible in those patients with a bit more of a translucent eardrum. I hope you enjoyed that video, guys, and you're all keeping well and safe and you enjoyed your Christmas. I shall speak to you all soon. Bye.